Hi, good evening, David. How are you? Well, thank you all for joining me this evening. We talked last time about normal aging, and now we're going to progress on now through understanding Alzheimer's disease and the other dementias. Since I have a lot of slides to go through and I want to make sure I answer all your questions this evening, I'm going to go ahead and get started. As you can see, that's our topic. This is an axon. The chemicals are electrical impulses as it goes through the brain, but when it gets to the synaptic cleft, it goes to the neurotransmitters. So it's very, very interesting how it changes from electrical to chemical. Well, let's look at some brain facts, some just fun brain facts first. So even though your brain is only about 2% of your body's weight, about 3 pounds, it uses 20 to 30% of the calories you consume and 20% of the oxygen we breathe. The brain is about 85% water. It's estimated that the brain has 100 billion nerve cells and more connecting in it than there are stars in the universe, which is about the number of stars in the Milky Way. And there's also trillions of supportive cells in the brain called glia. So each neuron is connected to other neurons by up to 40,000 individual connections, which are called the synapses between those cells. Multiplying 100 billion neurons times those 40,000 synapses is equivalent to the brain having more connections in it than there are stars in the universe. And a piece of brain tissue the size of a grain of sand contains 100,000 neurons and 1 billion synapses, all talking to one another. And information in your brain travels at about 258 miles per hour, unless, of course, you're drunk, and then things really slow down. I wouldn't know anything about that, of course. The best source of stimulation in the brain are physical exercise, mental exercise, and social bonding. Those three things are paramount in you having good cognitive health. On average, women say about 7,000 words, and men, they mismanage just over 2,000 words a day. Laughing lowers the levels of stress hormones and strengthens the immune system. 6-year-olds laugh an average of 300 times a day, and adults only laugh 15 to 100 times a day. So we also need to improve on that. And axons that are not insulated by myelin, either by design or disease, transmit signals 10 times slower. So you can see that when these myelin sheaths begin to disintegrate, that the communication is much slower. The myelin continues to be deposited to the prefrontal cortex until age 25 to 26, making the executive part of the brain work at a higher and more efficient level. These are all really interesting brain facts. So let's talk about memory loss, mild cognitive impairment, and dementia. All right. With the dementia, we're going to look at the types and disease progression. We're also going to touch on the losses associated with dementia before we talked about just the losses associated with normal aging. And then you can have some behavior changes that are associated with the disease process, and when we go through theirs, I'll give you some logical reasons why they certainly exist, and some medication side effects that you can have. So memory loss. What is just memory loss? Well, it's remembering a person's name. It's trying to remember recent events. If I could hear you all and asked you, what did you have 2 days ago for lunch? You probably can't recall it unless you ate the same thing for lunch every day. So it's just that we don't keep track of all of those trivial memories. Somebody who asks the same question more than once, I catch myself doing it. I hear my mom, who's 84, doing it to me all the time, but that's because her social network is so small. She doesn't remember what she told me versus my sister or my brother. And difficulty shopping. All right, there's so many choices now available to what you can shop for. You can't just go buy a white blouse, or you just can't go buy a orange juice. There's tons and tons of options available. Losing your car in the parking lot. All right, what's that? What's the first excuse when you've lost the car in the parking lot? Somebody stole it, the wrecker came and took it. It's always somebody else's fault, not that you've forgotten where you actually parked it. Or misplacing your car keys. I actually came in with my groceries one time, put everything in the freezer first, and then put everything else away. And the next morning I went to get in my car, no car keys. I was able to remember exactly what the progression was the day before. So yes, my car keys were in the freezer. So, but these are all memory loss. This is all has to do with our being distracted. You learn more in one day than a frontiersman learned in a whole year. So we are distracted. Our plates are full. We're multitasking like crazy. So this is just normal. Then if you look at mild cognitive impairment, and you might see a diagnosis of an MCI. And this means that a person experiences noticeable problems with memory, language, or other cognitive functions, but they don't interfere with anyone's daily life. They can write themselves notes, or just it doesn't interfere with their independence. So there are no deficits with reasoning and judgment with mild cognitive impairment, and it may or may not develop into Alzheimer's. So disorders that cause treatable memory loss. In 1995, when I was living in San Diego, the Alzheimer's Association there had a list of 102 reasons why you could develop dementia. And only 4 of those were incurable and progressive, and 98 of them were something that could be worked on or that was curable. And I've listed some. Depression can cause confusion and forgetfulness, grief, anxiety, and fatigue. Depression is huge in this country. Actually, by 2030, depression will be one of the major causes of disability worldwide. So depression certainly can behave like a pseudo-dementia. Someone can act like, walk like, talk like a person who is, a depressed person can do all those things just the same and act like a person with dementia, but it's really because of the depression not being resolved. You can have an acute physical illness or infection of the central nervous system. It could be from AIDS, herpes simplex, neurosyphilis, Creutzfeldt-Jakob, any of the neurodegenerative problems. It could be a brain tumor, brain lesions, meningitis, brain infection, and head trauma. It can be from normal pressure hydrocephalus, which is water on the brain. Most people thought that that was a disease that was gone a long time ago, but it is definitely rearing its head again. The blood vessel diseases, such as the cardiac disorders and stroke and TIAs, they can cause multi-infarct dementia. So electrolyte or hormone imbalance, chemical toxicities such as alcohol. Alcohol as a dementia is known as Korsakoff syndrome. Medications, adverse drug reactions from medications, and taking multiple medications, which can create polypharmacy, is another issue. Neuroepileptics, diazepam-related hypnotics, anticonvulsants, beta blockers, and digitalis. Any of these medications can cause somebody to have forgetfulness, memory loss, and confusion, and therefore have dementia-type symptoms. You can have metal poisoning such as lead, mercury, or manganese. Metabolic disorders such as hyperlipidemia, hypoglycemic, and hypo or hyperthyroidism. The issue with thyroidism is that not only can the disease progression cause dementia-type symptoms, but the medication side effects for that disease can also increase the person's level of dementia. Dehydration, even being 10% dehydrated, can cause you to have dementia-type symptoms. Dehydration not treated can turn into a UTI. Someone who has UTI that has dementia can go into delirium, and so they're not their normal self for that day, and that's how you know that they're not behaving like they normally do, and that's when you can order a urine analysis. Poor nutrition, vitamin deficiencies such as folate, thiamine, B12, pernicious anemia, all of these can cause dementia-type symptoms, as well as epilepsy, respiratory disorder, sarcoidosis, lupus, liver or kidney dysfunction. So you see there are a lot of ways that somebody could have dementia or memory loss, and so you want to diagnose it. If Alzheimer's is the diagnosis, it should be a diagnosis of elimination, that you've ruled out all those other reasons that somebody has dementia that could be curable or treatable. So what you see first in the decline is somebody begins to have problems with their instrumental activities of daily living, which are known as the IADLs. And this is someone's ability to use the telephone independently, to go shopping, to prepare food, to keep their house up the way they used to. That's how you'll notice. To manage their laundry, their travel, and that is in a bus, in a car, medication management, and handle their finances. What we see in care facilities are the families will fill in for all of the IADLs of life, but it's when someone needs assistance with the ADLs of life that it becomes much more difficult. And ADLs of life are the activities of daily living, and they include bathing, dressing, toileting, transferring, and that's just from the bed to the chair, it's not travel, continence, and feeding themselves. And usually in American culture, we have a little more difficulty in bathing or toileting our own parents or loved ones. So features of the brain, although the brain can be quite damaged, there's usually more that's not damaged, and that's what people in my profession work to. We play to the strengths of those who we care for. Some days are better than others for someone with dementia, and different parts of the brain have different jobs to do. So it depends on where the plaques are, or where the tangles are, or where the Pick's disease is, or the Lewy bodies. It depends on where these are, or the TIAs, where the damage is, as to the progression of the disease, or the behaviors or symptoms that you see. So you can see here that the brain has a lot of different areas that it covers. Sight being at you can see sort of at the back, touch sort of at the top, memory is up there also at the top, or I'm sorry, movement, and that's your voluntary movement. And then your intellect and personality, and that stands towards the frontal lobe. So somebody who has a frontal lobe dementia, you're going to see some changes in behavior. So with those issues in your brain, you might be able to see that you have a toothbrush, know what it is, and you can say it's a toothbrush and know what to do with the toothbrush, and you're able to move your voluntary muscles. The problem is that depending on where the area of the brain is damaged, you may be able to see it, call it by name, but not know what to do with it or any other combination. So you can see that it can interfere with the sequencing that goes on with all of the things that you do on a daily basis. So we begin starting to employ coping mechanisms, all right? So we start making up stories that seem plausible. So if you ask somebody how they got the bruise on their leg, they'll say, oh, well, I just hit the table right here. I just got it, right here. Of course, you know that the bruise isn't that fresh, and so probably that's a made-up story. Or they flatter you to distract you. All right. Oh, you look so lovely today. After you've asked them a question, they totally divert your attention. They make a joke. Well, how can you expect me to know? Or they get angry. Well, you can't expect me to know. Or they substitute things they know for things that they don't know. Like, what type of food do you like? I like good food. Or a well-traveled person, where have you been? Well, you name it, I've been all over. And that's how they avoid truly answering the question. And they always use socially appropriate phrases. You learned them from the time that you were 4 years old on. It's totally a stored memory in your long-term memory, and you'll be able to retain those for a very, very long time. So how would you know that if somebody you thought had more than just normal memory loss, or more than mild cognitive impairment? You would be looking at things like, do they have some short-term memory loss? Are they able to manage their finances? Are they able to pay their bills? Are they paying their bills more than once? We see that. Are they asking questions repetitively over and over again? Not just today, but throughout the day? Do they seem to be depressed? Are they anxious? Are they misplacing items or hiding them? Are they oriented to person, place, and time? Time is one of the issues that people get disoriented to first. What day is it? What time of day is it? How long till dinner? And you say 15 minutes, and they say, well, how long to dinner? So they can't remember how long things are. So changes to the ability to perform hobbies or household tasks. You might notice a loved one not keeping their home up the way they used to, not cooking like they used to, or you might notice a coworker who is now having some issues with occupational tasks. So what should you look for true diagnosis? All right, you need all of these things if you suspect that somebody has dementia, because you want to find out whether the person has something that is curable or treatable or is actually progressive, and what type of dementia it is, so that you know what type of medications would be appropriate if that's the path you chose to take. So you want your physician to look at your blood work and do a medical examination. You want a neurologist to examine to rule out any kind of tumors or strokes or water on the brain. If you're a family member and you're taking a loved one, or a caregiver and you're taking a loved one to see a doctor, you want to share those anecdotal stories about how, yes, someone's not taking care of their home, or they don't seem to notice that food is spoiled in the refrigerator, or they're not taking care of their personal care items anymore. You want the physician to know that. But if you sit there and say, my mom is not taking care of her house anymore, and she doesn't seem to take a bath, and she doesn't brush her teeth anymore, and she doesn't wear her teeth anymore, if you say those anecdotal stories in front of your loved one, you will alienate them. They're not going to tell you those things anymore. So if you need to share those anecdotal stories with the physician, I highly recommend that you write a letter beforehand, or you make a call beforehand, that don't discuss those things that put that person in a bad light in front of them, because then they won't share with you anymore. So you want even to tell them all of the medications that the person is on and anything that they take over the counter. So you also could use a geriatric psychologist, and they will be able to evaluate for depression or mental health issues such as paranoia or schizophrenia. I talked last time about all these multiple losses that someone has. In this older population, going to see a psychologist was rather a taboo. So there may be a lot of multiple losses. They've lost their home, they've lost their spouses, their siblings, their parents, maybe a child. They've lost their personal possessions, they've lost the ability to drive. There's a lot of losses, and so they may need to talk to a mental health therapist. One of the tests that someone would be given is called the MMSE. It assesses the level of consciousness. Somebody notes on it how the person appears, whether they're disheveled or whether they're well dressed and have good ADL care taken care of them, that they've had a shower, that they're freshly shaved, and they watch their behavior, mood, speech, language, and perceptions, and beliefs, and cognition. I highly recommend that you take somebody to a memory disorder clinic where they can have the whole gamut of tests, not just one single test. This is my view on the mini mental state exam, is that there are outside factors that can influence the score. The tester's method of asking the questions or prompting the cues. The first question goes about asking, the day, the date, those type of things. But then they ask you to remember 3 words, and maybe it's a piece of furniture, maybe it's a toy, maybe it's some food. But whatever it is, they ask you those 3, and then they ask you a math question. And the question is, I'd like you to start counting backwards by 7. So everybody goes 93, and then they go, oh, I'm not very good at math. I don't think I can answer that question. Just go ahead on to the next question, all right? But if I said, I have $100, and I'm going to go buy a $7 item, how much change do I get back? Remember, this older generation can make change very, very well. So now I have $93, and I'm going to go buy another $7 item. How much change do I get back? And you now instantly know the know the number. If I apply it to things that you know, then you're able to answer that question. But if I leave it at just please start counting backwards by 7, and I need you to do it 5 times, then people get anxious about that. Test anxiety, it depends on also what I said. With this older generation, it's more comfortable for them and more acceptable if I sit down with them and say, hi, I'm Vicky, and I'm here with the doctor today, and I have some questions to ask you, and these questions will help the doctor identify how best to help you. Or I can say, hi, I'm Vicky, and I have a test, and it's just a 30-point test, but it's going to tell the doctor whether you have Alzheimer's or not. So it really depends on whether I create test anxiety or I don't. And this older generation, they expect you to build a rapport before they start asking or answering questions. Education level is also to be factored in, and depending on where you purchased the test samples, depends on whether you will get that information about education. Whether if somebody's had less than an 8th grade education, you have to factor that in. It depends on where I buy it, whether you're mildly cognitively impaired at 24, 25, or 26 on the score. And remember, if I ask you to start counting backwards by 7, and you said 93 and then gave up, you've already missed 4 out of 30. The time of day. Some of you are morning people, some of you are evening people. So you morning people, it would be fine for you to have a test at 8 o'clock in the morning. But for the afternoon folks, they would probably do much better later in the day. Now you morning folks, if I waited and then you had your lunch and it's now about 3 o'clock in the afternoon, I don't think you're going to score quite as well on the test. Just my thought. Maybe you're an auditory learner, but since more than 75% of the population are visual learners, by giving you an auditory test, you may not score as well as if I gave you a copy of the test to look at while you're taking the test. And there's nothing in the rule books that say that you can't ask for a copy to look at while the person's asking you the question. Maybe your health for the day isn't very good. You've got a cold, you just are not feeling up to yourself. So you don't want this test to only be administered once, because remember, with dementia, I can have a good day and a bad day. So you need to give me the benefit of the doubt on my good day or my bad day. This test should not be used alone to determine the diagnosis. So you don't want to go to your primary care physician telling, gosh, I've been kind of forgetful lately, and he gives you the MMSE, and then he says, well, it looks like you might have some cognitive deficits, so we're just going to put you on this and this medication. Because then you haven't ruled out all those reasons that were treatable, that you might have deficits with. So that's my viewpoint on the MMSE, just my viewpoint alone. So dementia is a loss of brain function. We've talked about memory loss and mild cognitive impairment, and now we are looking at the dementias. All right? There's no typical person with dementia. It depends on where those areas of the brain are that are being injured by any of the incurable and progressive diseases. So you could have a room full of people with Alzheimer's, and each of them will be an individual. There are no blanket people or blanket definition. It's not a single disease. Dementia is not a single disease. Instead, dementia refers to a group of illnesses that involve memory, but also behavior, learning, and communication problems. So dementia may be diagnosed when a person has chronic problems in brain function in more than 2 areas. So you must be memory impaired plus have a problem with behavior, communication, or learning. Now delirium, remember I said, is a very rapid change in thinking and alertness. And in that situation, this person's having a really bad day. All of a sudden, you need to seek medical help immediately for someone with delirium. UTIs certainly flare up looking like that. And depression Chronic, unless treated, poor quality of life, no pleasure in their past interest. These people say, I don't know. I don't know what I want to do. I don't know. I just can't. Responses. And so if somebody has depression, it needs to be treated because it truly looks like a pseudo-dementia. So with depression, there are many, many screening tools. The Geriatric Depression Scale or the Beck Depression Inventory are to name just a few. Studies suggest that between 20 to 30% of patients with dementia in early stages develop major depressive disorders, and between 30 to 40 in mid-stage. Studies show that someone with Alzheimer's, who, if you're following Riceberg's stages of dementia, that up into the fourth stage they probably have some depression because they know that they're going to forget, and by the fifth stage they've forgotten and no longer need antidepressants if they were administered in the first place. So as you can see, dementia is the blanket, all right? Now, the four progressive and curable ones, Alzheimer's disease being one. Then you have vascular dementia. You have Lewy body dementia, and Pick's disease, and we're going to talk about those in depth. But the other dementias were all those other reasons, all those 98 other reasons, and I'm sure there are more now, that somebody could have dementia. And if it's simply something like folate, thiamine, or B12 deficiency, wouldn't you want to know that and correct it immediately? So these are the four that are incurable and progressive. So even with that, remember that each person is unique. The severity and the range of the symptoms depends on the cause of the disease, the state of the disease, where is it, how is it progressing, any pre-existing personality factors. If I already had mental health issues where I hallucinated, then hallucinations in the illness, it's hard to tease out which one did they come from. Environmental supports. Is my home, if I truly have Alzheimer's, is my home environment overwhelming? Is my care facility environment overwhelming? Or is it supportive? We call it the environmental press versus the environmental fit. So social supports, as I said, they're extremely, extremely important to have them and to maintain them. Presentation of other diseases. Most people don't just have a diagnosis of dementia. They also have COPD or CHF or any of the heart problems, cancer, diabetes, any of the 10 reasons, 10 top reasons why we have death in this country. You have a lot of comorbidities, generally speaking. The area of the brain that's being affected, as I said, it depends on where the plaques and tangles are, or the Pick's, or the Lewy bodies. And the level of fatigue or stress. If you're at a very high level of stress all the time and you're on fight or flight all the time, that in itself can cause the shrinkage of the hippocampus. The hippocampus is about the size of my thumb. This is the top portion, and it's divided into two hemispheres, and it's very small, but it's where all your short-term memories go. So you need to eliminate the stress in your life. So let's look at Lewy body dementia. All right, there are abnormal deposits of protein which form in the brain's nerve cells and can cause a degeneration of part of the brain stem. There are early hallucinations with somebody with Lewy body dementia, whereas the hallucinations for somebody with true Alzheimer's might be at the very end instead. They tend to have Parkinsonian type symptoms. They have a flat effect of their emotions, so they don't smile, they don't laugh. They have reduced blinking. They have reduced arm swing, so now they develop gait problems. They have movement problems with episodes of muscle rigidity, just like somebody who has Parkinson's. They can develop tremors. They can have fine motor problems with their hands and even problems with swallowing. And they move slowly and sluggishly. They shuffle when they walk, and they tend to stoop over, which all of these tends to make them a risk for falls. Their mental function varies from day to day and often dramatically, and that's what I was saying about some days they're good days and some days they're bad days. They have mood changes. They can become depressed, and they can also become aggressive. They can have some daytime drowsiness, and so you can see that then they're up more in the evening because they've slept periodically throughout the day. They have rapid eye movement sleep disorders, about 50% of them. So when they have those nightmares or vivid dreams, they actually move. They actually um, throw out their arm and hit their spouse or something. But they are actually physically engaged in the dream. So the treatment right now are the cholinesterase inhibitors, which are the same medications as for Alzheimer's. Um, and they're also being given Parkinson's medications. However, when somebody that has potential Lewy body dementia that you believe might have this, you need to hold off on any kind of antipsychotics that might be given for their behaviors or for their depression, because they tend to have extreme and severe reactions from those medications. They have abnormal depth perception, so this gives them that impaired visual spatial skills, so they can walk out their own door, head to the mailbox, and maybe not know their way back. They might not be able to eat as they get it on the fork and they get it to their mouth, they spill it off, and that's a visual spatial skill. They might knock over something that's in their peripheral vision. So Lewy bodies have also been found in persons with Alzheimer's and Parkinson's disease. Because the Lewy bodies may be widespread throughout the brain, the memory areas can look just fine on imaging. This appears to affect more men than women, and the expected survival rate from the time symptoms begin was 6 to 12 years. However, all of these years that I'm going to be telling you about have been extended because we can keep you alive a lot longer. We can give you plenty of quantity of life, not necessarily always quality. So here's what a Lewy body looks like, if you like pictures. And here's another one. And these are what Lewy bodies look like on the brain's cortex. So characteristics are probable Lewy body dementia is defined when one meets 2 out of these 3 symptoms. So if they have fluctuating cognition with clear variations in alertness, they have a really dramatic good day, bad day. They have recurrent detailed visual hallucinations, so they see things that are not there. They may also have hallucinations on the other senses, but predominantly people with Lewy bodies certainly exhibit visual hallucinations. And they can have those Parkinson's symptoms, such as the muscle stiffness, the rigidity, and the slowed movement. So somebody with Lewy body dementia has to exhibit a problem with at least 2 of these areas, 2 out of the 3. So you're looking at, do they have sleep disturbances? Do they have gait disturbance problems? Do they appear socially withdrawn? Do they have variable symptoms, that high lows, hallucinations, disorientation, suspiciousness, wandering, apparent slowed processing, both verbally and physically, and other behavior problems. Excuse me. So now let's look at Pick's disease. Okay, Pick's is a frontal lobe dementia, and a clinical syndrome associated with the shrinking of the frontal and the temporal anterior lobes of the brain. So that's the lower side of each cerebral hemisphere, and it contains centers of hearing and memory. They have early loss of personal awareness and mood swings and behavior changes. They can become impulsive, disinhibited, and then you'll see some inappropriate social behavior in public, or bored and listless, and then they become depressed, apathetic, and socially withdrawn. So you can have either the high or the low. They have a loss of insight into the behaviors of oneself and others, and so therefore that reasoning and judgment about what is socially correct and what is socially not the norm, it has been given up, lost. They can have a lack of empathy for others, so they don't necessarily care if they upset other people or outrage other people. They can have a neglect of their personal hygiene. They may have repetitive or compulsive behaviors, and in this, they may become orally or anally fixated. They can have increased interest in sex. Why I want you to look at that is when I talk to you about Namenda, one of the side effects of Namenda is that it can increase the libido. So if it's someone with Pick's disease and they are exhibiting an increased interest in sex, Namenda might not be the best idea, depending who you are. Decreased energy and motivation changes in food preferences, and agitated or blunted emotions. It's going to be either side. With language, they may have expressive or receptive aphasia. Expressive aphasia is someone's ability to express themselves. Receptive is the ability to understand others. And in that receptive aphasia, if that's the issue, then they have a lot of difficulty in following directions. Because someone's expressive side is affected, does not mean that they cannot understand every single word that you say, and they may understand everything you say and not be able to express it, or the reverse. Their spatial skills and memory remained intact. It occurs between the ages of 35 and 75. There's a rapid progression on this one, but again, 2 to 10 years is a guideline. Cholinase inhibitors only work about 1 in 3 times with someone with PICS, and those cholinase inhibitors are the same medications that we'll talk about that someone with Alzheimer's can have. And antidepressants and serotonin uptake inhibitors are being tested currently. These are what PICS look like. These are little tau inclusions. And here's another picture, and this is in the cortex again. So if you're looking at somebody with Pick's disease, judgment and insight can be damaged. Decision making, they may be very impulsive. Mood changes such as depression and apathy. An alteration in their planning and their ability to initiate. Susceptibility to sweepstakes. We often hear somebody who's lost their entire fortune by playing the sweepstakes. Compulsive behaviors. Speech and language issues, socially or sexually inappropriate. Remember, they don't have that knowledge anymore of what is right or wrong. And again, you can see work-related problems if somebody's developing PICS and who is still in the workforce. So now, the third one is vascular dementia. This is caused by impaired blood flow to the brain and a series of strokes. Memory impairment, if strokes affect brain's memory regions. This is a stair-step progression. Your Alzheimer's is going to be very much a down the curve. And with your vascular, though, it's going to be a stair-step progression. You're going to see them have a TIA, and then there's going to be an immediate decline, and then they're going to learn how to cope at that level, and then they're going to have another decline at the next TIA. So there are very noticeable changes in that fluctuation. They have problems with concentration, planning, expressive communication, and or receptive communication, such as following instructions and even doing their daily activities. They can be confused, especially at night. Brain MRI may be used to detect the vascular abnormalities. Current methods of treatment is to manage the risk factors, like the high blood pressure, like the weight, the sugar intake, the cholesterol, and if the person smokes. I did not say that the current method of treatment are the cholinase inhibitors. This is a vascular problem, not a neurotransmitter one. So the goal is to prevent further strokes through diet and exercise, and what's good for the heart is certainly good for the brain. And the Alzheimer's Association on their website has a lot of information about brain health. So here you can see infarcts and lesions in the white matter, and you would be surprised. I recently had an MRI, and I already have lesions in my brain matter. I have a family history of heart disease, and now I have one of my very own. It is causing lesions in the white matter. so of course I have to manage my risk factors now. So again, you can see vascular. At the bottom, it shows you where the infarcts are, and to the right, there's one with lesions. The characteristics of somebody who is developing dementia because of their vascular issues is that they have changes in memory and cognition. They have issues with decision making. They have sleep disturbances. They can develop apathy, sensory loss, physical limitations, or language problems. These characteristics, not everyone is going to have all of them. It's just like side effects of medications. It's a couple, some of them. Not all. It's not usually all of these. Alright, so the last one we're going to talk about is Alzheimer's disease, and the one you probably know the most about. This is an irreversible, gradual progression, and it's different for each individual. The plaques are the beta amyloid proteins and the tangles. This is the theory that has been in existence for, well, it's been looked at for 100 years, but it's been in the news, I'd say, for the last 20, and there is another new kid on the block, which I'll present in just a few moments. So the problems with Alzheimer's disease is, and how I learned it was Palmer initially, these people have problems with perception and organization of movement. So they're not able to get from point A to point B nearly as well as they could. They have attention span, which is short, so they have difficulty with initiation. They have expressive and receptive aphasia, or either or none, depending on the disease. Their memory, they have difficulty remembering new information. They can have problems with their emotional control if the plaques and tangles are developing in the frontal cortex. And they can have problems with reasoning and judgment, and this is what you see first, at least in my experience. So here are the plaques and tangles. You can see a healthy cell where it has the electrical impulses going on, and then you can see the cell that is now damaged. All right. With the plaques, the theory was that as the cell is cleaved, that an amyloid beta protein was cleaved from it, and it was like a little sticky thing. And then another cell that was cleaved improperly again near it, so now you got those sticky things. And so the sticky things all kind of got together. I know this isn't scientific, but it's my best shot at it. So once they got together, it's kind of like a wad of gum. And then they bump up against the cells. And the cells had an inflammatory response. And so your immune system comes in and it takes out that cell that was then pressed by the plaque from the outside, which is different than the tau protein theory, which says that those little axons and dendrites, there's a CDK5 enzyme that causes it to fall apart, as you can see in the slide. It falls apart, and those little things become tangles as the molecules fall apart. So a new theory, and this is truly just out this year, is that the cause is not the plaques and the amyloid protein. So that the cause is by the buildup of clumps of material formed by the breakdown of protein. That idea hasn't changed, but it's now what the protein is has changed. So Sam Gandy, he's a physician, he's also the professor of neurology and psychiatry, and he's the associate director of the Alzheimer's Disease Research Center in Mount Sinai. He says that it's not the amyloid plaque, but that it's the amyloid oligomers. And he says that the brain tries to remove the offending oligomers by forming the plaques, which he says that the plaques are brain pearls, that they're there in the body's response to get rid of the other. Interesting concept. He says that just as an oyster creates a pearl around a grain of sand to protect itself, the plaques may serve as traps for the oligomers that are attacking the brain, Researchers have found that some people who never have dementia nevertheless have brains inundated with plaques. And this was in the nun study, that they found that nuns who had an extremely similar life, similar routine, similar education, similar physical, um, that some of them developed dementia and some of them did not, but they all had plaques. So Gandhi thinks that plaques are a sign that your brain was trying to do something very beneficial for itself, and if you go in and take these plaques apart, you're going to make the oligomers, and that could actually be worse. So that's his theory. So this would start a whole new research, because so far they've been trying to figure a way to stop the amyloid plaque. So they'll have something new to look into. So it'll be interesting. This slide I was able to get, and it is showing the oligomers, but the slide actually came from a diabetic study. But you can see that the damaged one is the red one, and the live part of it is the green. New concept, new way of looking at things. So Alzheimer's disease affects the brain by destroying the neurons. New information is lost. Their recent memory becomes worse. Their word-finding difficulties. They misspeak. They start filling words in that sound sort of like they'll fit, and they're hoping that no one will notice. They're more impulsive or indecisive because there's that lack of initiation, and they can get lost. And a lot of that is because of that visual spatial problem. So this slide is a little skewed, but there are several A's with the Alzheimer's disease, and they can have amnesia, which is just a memory deficit. So they have difficulty registering, or we're calling new memories. They can ask the same question over and over. If that's the situation, you need to validate them and don't get annoyed if they ask you the question. Then you answer it as if it's a brand new question every time, because for them it is a brand new question. It's sort of like they asked you the question, it came in, they validated you, they acknowledged what you said, and then it went into one of those black holes, and so now they're asking you again. So one of the things that we have found is that people with Alzheimer's can read your body language. They may not understand exactly what you're saying, but they can read your body language extremely well. And 55% of what you say is seen in body language. So if you're becoming annoyed, they can see that. They don't know why you're annoyed. They just know that you've become annoyed. So you really just have to accept the repetitive questions when you're working with folks with dementia as a new question every time. You would answer it as a new question if it were a new person. So you have to answer as a new question even if it's a repetitive question. They can also lose their belongings, okay, because they can't remember where they put things. I do that all the time. But then I swear my husband moved it. So aphasia, we talked about that. You can have expressive, which is the inability to produce speech, develop word-finding difficulties, fill in with odd words, and later speech becomes vague and empty. With receptive, they're unable to understand words, and that can be written, might be retained or spoken, so you need to use visuals. If they're having problem with language one way, then use visuals so they know what the topic of the conversation is. Agnosia is recognizing the world. They have difficulty interpreting the world that they see. They're unable to recognize objects, people, sounds, shapes, or smells. So sometimes they look in the refrigerator for milk, but they don't recognize it. And later in the disease process with Alzheimer's, they think that they're younger. All right, they forget that they are the person who's reflected in the mirror. And what I see quite frequently is that they get coded as resistant to care, and then they get put on psychotropics for that. And it's really agnosia. The issue is they don't recognize themselves. In American culture, if you go into the restroom and you see someone's there already, you back out. That's what our culture says. You've learned that since you were 3 or 4 years old. So if they don't recognize themselves in the mirror, say in a nursing home, the nursing home regulation is that they have to have a mirror, but it doesn't say that you can't soap it or cover it or move it to the back of the door. So if they're not recognizing themselves in the mirror, then the bathroom becomes an issue unless you deal with the mirror. They don't recognize caregivers, but they will track them, but they might not recognize them. And sometimes they don't remember family members. If I've forgotten that I married, and then my children come in, and they look like their father, I don't know who they are. I haven't met my husband, so I don't know who the children are that look like him. Now, if children come in and they look like me, or my family, then they'll become my mom or my sister or my brother or my uncle or my niece, my nephew. So you see often in sort of care plan meetings in long-term care is family members will argue. You know, I come to see mom all the time, but she doesn't know who I am, and you come every now and then, but she knows exactly who you are. And then I'll usually say, which parent do you look like? Because if you look like the father, then I know immediately that she has agnosia and she has forgotten that part of her life. If she doesn't recognize the children who look like her spouse, then she might no longer respond to her married name. And so then you need to start calling that person by their first name or their maiden name so that they'll reply. It's not necessarily a hearing deficit. It's she doesn't know who that married person is anymore. They don't, and they can become uncooperative or run away. It's wandering or elopement. They're so confused by their environment. They're looking for home, what they consider home, whatever that may be. Someone with anomia is unable to name objects. We've done that before. You know, it's that thing, you know, you have it on your arm and, you know, it tells time and it's got a battery in it. And you come up with all of these descriptions, you just can't think of the word. So, now, apraxia is doing things, and this affects the part of the brain that involves planning and directing the body to do things. So if you come up and you try to offer me my sweater, now you know I can use my arms because you've seen me to eat. But right now, with you standing with my sweater, I'm not able to tell my brain to move my arm. And so that's apraxia. There's nothing wrong with my arm. There's nothing wrong with the musculature. It's just I can't make the connection for a voluntary movement like that. So putting on their clothes, eating with their hands instead of using utensils, you'll see these type of things. The motor function and the sensation are still intact, but they just can't coordinate that voluntary motor activity. And tasks must be simplified. You need to cue them, tell them what to do by demonstrating it yourself. My father has Lewy body dementia, and initially he had trouble shaving. So we started laying everything out so there wouldn't be so many steps. And then he couldn't do it after that. So then I said to my brother, okay, when you come by, will you shave and let our dad watch you, and he'll mimic you. It's called positive mimicry. And so that worked for a while. Unfortunately, that no longer works, and he has to be shaved. But we employed all of the strategies that we could to keep him and his independence for a very long time. If I asked you how many steps do you think it takes to brush your teeth, and I gave you a few minutes, you'd probably come up with, I don't know, maybe 5 or 8. You got to get out, but you got to get the toothbrush and the toothpaste, and and you got to brush your teeth, and maybe the cap issue would be come in. But I can actually tell you that I've done an analysis, and I came up with 57 steps. When you brush your teeth, is an amazing amount of times that you switch from dominant hand to non-dominant hand. You could get out the toothbrush with your dominant hand, but now you got to put it in your non-dominant hand to pick up the toothpaste. and then you use your non-dominant hand to open the toothpaste, but you still got the toothbrush, but some people can't do that, so they lay it down. My sequence may not be the same as your sequence. Some people leave the water running. Some people don't. Some people like their toothbrush moistened before they use it. Some people don't. So it's a lot of sequencing that goes on. And that's where apraxia and the ability to think out all those voluntary movements becomes an issue. With stages of Alzheimer's, there's several different types. The stages of Alzheimer's are just markers, all right? I don't want you to think that person is in stage 4 and then they move to stage 5. No. They have some of 4, maybe some of 5. Today they're more like a 3. So these stages fluctuate. They're really just markers. They're used for frame of reference, as not everyone will experience all the same symptoms. They have the same disease progression, and each person may fluctuate between and among stages. So please just consider them as a marker. You might have heard mild, moderate, or severe, or you might have heard early, mid, or late. And Barry Weisberg has also come up with 7 stages. I've even seen it elaborated out to 21 stages. So if you look at the 4 that we've been talking about, Alzheimer's disease has memory, repetition, and confusion, whereas Lewy body has early hallucinations and variability in movement problems. And these are the ones that you don't want to give psychotropics to. Then you have frontotemporal dementias, and you've got behavior changes, apathy, language problems. And with vascular dementia, it totally depends on what the type of the heart disease is and what type of damage has been caused in the brain. So those are the 4 that are incurable and progressive, but everything else is curable or treatable. So let's look a little bit at medication management. There are 3 cholinase inhibitors which increase the levels of acetylcholine. Acetylcholine is one of the primary messengers that works in the synaptic cleft, and it is definitely involved in memory. So Aricept is approved to treat all stages of Alzheimer's, all right, mid, moderate, or mild, moderate, and severe. There are 5 milligrams or 10 milligrams. If someone tolerates the 5 milligrams and does well on it, they can eventually be moved up to 10 milligrams if it's needed. If they're doing fine on 5, you can leave them on 5 and then later move to 10. 10 has about 3 times more side effects, and it's coated with iron oxide. Someone who cannot tolerate iron can have a side effect of diarrhea then. So in a population that weight loss is already a problem and dehydration is already a problem, it's maybe something that you might want to consider. Exelon is approved to treat mild to moderate, but not severe. So it comes in liquid, it comes in pill, and there are also patches. Razidine, which was formerly Reminol, is approved to treat mild to moderate Alzheimer's. Again, not severe, and it comes in doses of 4, 8, or 12. Memantine was approved in 2003 to treat moderate to severe. It regulates the activity of glutamate, so it doesn't work with the acetylcholine. It works with the glutamate, which is a different messenger chemical involved in learning and memory. In 2005, the FDA declined to approve it for mild. So I don't know that it has been approved for mild as of this date. So therefore, it would be a moderate to severe. It's prescribed to improve the memory, attention, reason, language, and the ability to perform simple tasks. If you look at the 4, I would like you to just take a moment to look at the side effects. All of the cholinase inhibitors can cause nausea, vomiting, loss of appetite, and increased frequency of bowel movements. Namenda, or memantine, however you want, can cause a headache, constipation, confusion, dizziness, and hallucinations, So if someone already has a propensity to hallucinations, then you have to outweigh the risks and the benefits of introducing a medication that has a side effect of increasing those hallucinations. The same issue of, depending on how confused they are, whether this medication will make them less confused or exacerbate the situation. Um, so just a moment of beware. And memantine is also the one that if somebody had Lewy body dementia and is sexually active, or sexually promiscuous, or behaving inappropriately sexually, um, you need to consider whether you want them to have an increased libido or not. In a care facility, I can tell you that that's probably not desirable. I had a wonderful lady in adult daycare, and her family they were trying to do everything possible, but when they added memantine, or Namenda, to her regime, she became so sexually inappropriate in the adult daycare, that she was no longer appropriate to be there, and that was very sad. So losses associated with dementia can be that feeling of loss of sense of self. If I can't remember all of my past experiences, how much of me am I? Um, there are your past memories. What if you lost those? What if you can't remember who your family members are? What if you have an increased loss of autonomy, privacy, independence? We talked earlier about the normal aging. So again, maybe you can no longer drive with dementia. Maybe you can no longer care for yourself or care for others, as you had in the past. So behavior issues. Um, a lot of medications can have side effects of aggression and agitation. So I want you to consider that as a risk versus benefit. When you look up medications, you can look them up in pdrhealth.com or rxlist.com. Uh, there's no charge for that. And you can look at the potential side effects of the medications. And if you see that there are medications that are multiple medications that someone is taking for aggression, or that is taking for multiple diagnoses, and they have a side effect of aggression and agitation, and this is what you're experiencing with this person, you might want to find out which medications can be removed if possible, or if there's a medication in the same family that doesn't have those side effects. You can also have angry physical or verbal outbursts. What I see often is because that person's personal space has been invaded without asking. In America, we have about a foot and a half that is our private space, and if you intrude in our private space without asking, we don't necessarily like that. Think about if you go to a church, or you're on a metro or a bus. Don't you always leave enough space between you and another person for actually another person to sit, which is about that foot and a half? If someone comes along and says you all have to squish up, don't you look nervously at each other and kind of give each other the silent nod of okay, and then squeeze in together, but now you're both uncomfortable. So in American culture, I believe that some of these behavior changes that you see are because we don't ask permission to invade someone's personal space. Confusion is part of the disease process. Medications that say they can cause confusion or memory loss or forgetfulness, sorry folks, those words all are very similar to me. And so if you're taking multiple medications that can cause those effects, again, you need to look at the risk versus the benefit and see if you can change out some of those medications. Hallucinations we've discussed. You would be wary of putting somebody on a medication that can cause hallucinations if they already have a propensity for that. Sometimes they have repetitive behaviors, where as they ask you the same question all the time. That's because the hippocampus is damaged, the brain is shrinking, and they have axons and areas that are damaged, and so they take the information in, they acknowledge that you said it, and then they forget. And so you just have to be open to continually answering that question. Didn't you answer your children's questions when they ask you them over and over and over again with all the patience and love that you could drum up? It's the same situation. Perseveration is either the repetition of a sound or the repetition of a movement. So depending on what it is, quite often it's related to something work-related in the person's past. I had a pharmacist who would touch the table and very, very, very slowly, eventually, touch her tongue. And then very, very, very slowly, she would again touch the table. And she would repeat this all day long. So people would put her in her wheelchair. They would lock her brakes away from the table so she couldn't touch the table. They would keep, every time she pushed the tablecloth away, they would come by and push the tablecloth back. And really, was this behavior hurting anybody? No, it wasn't. So finally, in her care plan meeting, I spoke with her son and said, you know, what did your mother do? And, well, she stayed home and took care of us. I said, okay, but before she married your father, or early in your childhood, did she work outside the home? Oh yeah, she was a pharmacist. And as soon as they said she was a pharmacist, and looking at the cohort that she came from, or her age, I remembered from the movie It's a Wonderful Life that, you know, before we had machines to capsulate medications, people hand capsulated. And so she was testing the med to make sure that it was what was on the bottle, and then she was trying to capsulate it. And then she kept doing this all the time. So I care planned that she was working. Isn't that really what she was doing? She was working. And once I could explain to all of her caregivers what she was doing, it no longer bothered anybody, and the woman was, you know, left in peace to complete her work-related tasks. So sleeplessness, there are many reasons why someone could be not sleeping well. Even if you're on blood pressure medications, they can cause insomnia. So there are many, many medications that can cause insomnia. There are issues such as, say, in a care facility, that in my house, in the morning, I see the sun rise. So what if you move me to a facility and you put me in a room where the sun sets? Well, I'm going to see the sun on the horizon at some point. So if my room is now on the other side, then that trigger alone can reverse my clock, my circadian rhythm, all right? Or have you, I want you to think for a minute about the placement of your bed in the bedroom. So, okay, you got it? All right, now I want you to turn it on to the other wall. It's like going to a hotel where the bed, the orientation of the bed is wrong. It's uncomfortable. It causes you can't fall asleep as well. I mean, I've gotten so desperate before that I'd actually put the pillows at the foot of the bed if it's been that bad, and I'm totally confused spatially. So medications, their biological clock getting turned around, shift workers, all right, nurses who were shift workers, or people who worked in factories, you know, not everybody sleeps at night. They just don't. So you have to look at all of those factors when you're looking at somebody and their sleep problems. Sundowning, there's a lot of explanations for sundowning. Sundowning, if you think of this older cohort, or older population that we're working for, if a homemaker in 1950, and you can look, you can Google the recommendations of a 1950s homemaker, and a 1950s homemaker, no matter what she was doing during the day, she could be out playing bridge, she could be out shopping, she could be out golfing, she could be anywhere doing anything. But by 3:30, she needed to be home, because at 3:30 the children came home. And she was trained that when the children came home, she needed to be there. She needed to have them a snack. The rules were that she would supervise their homework because that was supposed to be done before Daddy got home. Then, around 5 o'clock, she would make sure that dinner was started, that the children were finished with their homework, that the little darlings were clean and ready to receive their dad. She would go upstairs. She would do her hair, make sure that her lipstick was nice, just check everything out. And if she was wearing cotton stockings, she was just supposed to change into silk stockings. Now, men of today, that is never going to happen for you. But that is how a woman of the 1950s was trained. And so, especially when they're living in care facilities, 3:30, that's shift change. So they get this total cue that everybody's going home. I mean, if you've ever been in a care facility, you know that the volume, with everybody talking, they're doing their reports back and forth to each other. The CNAs from this shift are talking to CNAs of that shift. They're catching up on, what they did over the weekend. And so you've got all of this commotion going on. If everybody's grabbing their coat and go, I want to go home too. So how are you going to convince me that I have to stay here? If you say it's my home, I'm going to tell you it's not. You're going to have to come up with a plausible reason why I don't have to go home. Are my children staying late for sports? Is somebody that I know and trust picking them up? Is my spouse picking them up? And at 5 o'clock, what you'll see is that the men are ready to get their lunch boxes or their briefcases and go home, because the little woman will be quite upset if they're not home for dinner. So there are all these cues as to why people sundown at the time of day that they do. Delusions are where someone believes that something is not so. I mean, it's like if I have agnosia and I look in the mirror and I don't see myself anymore. Actually, I'm beginning to see more of my mom in the mirror than I am of myself, but that's normal aging. But if I don't recognize myself, then you can say that I'm delusional because I don't know who the person is in the mirror, and it's myself. Suspicious? Wouldn't you be suspicious if you can't find your stuff and you don't know where your stuff is and you don't know how to get from one place to another and you're not sure where you are? Won't you become suspicious? And hoarding, all right? Remember, this is a population that came through the Depression. If I don't have a lot of stuff, then I'm really going to hold all the stuff I can, all right? So you might find residents who pilfer and then hoard whatever they collect, all right? But remember, they didn't throw anything away during the Depression. I'm a big collector, and I don't know about you, but I have a house that has lots of stuff. And if I have to move from my house and move into an independent living facility, I'm going to have to get rid of my stuff, some of my stuff, all right? Now, some of my stuff I can part with without any emotional attachment. And some of the stuff I can give my son, but I know he's not going to take care of it. He's not going to appreciate it. So now I got that emotional baggage. So, all right, but in independent living, I'm probably in a 2-bedroom apartment, which I haven't been in since my 20s. But then something happens and I have to move to assisted living. Well, now I'm really in an efficiency apartment. So my china, my hutch, my big dining room set, I'm down to 1 bedroom. I don't have an office anymore, or a library, or a sewing room. So I don't have my stuff, and it's getting to be serious. And so if I have dementia, I might be looking for some stuff that looks like my stuff. And then what happens if I move to a nursing home? And now I have a broom closet that they want me to put my clothes in, because that's about the size of it. There are maybe 4 drawers. Good, I'm happy about that. And I might have a nightstand that has 2 drawers. Where am I going to put all my stuff? Right? The fire department won't let me put my stuff on top of the wardrobe, and I can't put any stuff under my bed either. So I don't have a lot of stuff. So the little bit of stuff that I have, I'm really going to hoard, and I'm going to safeguard, and I'm going to see if I can't get some more stuff to add to my collections. I don't know about you. But you can see that hoarding behavior has a lot of sense to it. Unpredictable situations, like that inappropriate sexual behavior, those might be behavior changes that you see. Wandering, a lot of people wander because they're people that needed something to do. They're not the people that could just sit. This older generation were raised with a very strong work ethic, so this sitting and relaxing all of this time, not really normal for them. If they had Victorian mothers, Victorian women were not allowed to sit with nothing in their hands. It was considered idle hands were the devil's workshop. And so women may have grown up with needing to be doing something all of the time. This concept of sitting down and relaxing and hanging out and not doing anything really just came in with the baby boomers. It's not something that our older cohort is so familiar with. And then catastrophic reactions. Catastrophic reactions can happen when somebody is truly overwhelmed by their environment or a situation. If you're ever involved in a catastrophic reaction with someone, they can be angry with you if that's who they're angry at, all right? So say somebody is really, really angry with me. And the longer I stand here, the angrier they're going to get. So what I need to do is remove myself from the situation. So I need to get someone else to come in. And that's called change of face. What you're using, or what you're doing, is using somebody's short-term memory to your advantage. Because the new person who comes in, the person with dementia can't recreate why they're so angry. And then that new person, because the person with dementia has so much adrenaline pumping, will offer to do something physical with that person. Go for a walk, have them assist them with something. You cannot tell somebody who's having a catastrophic reaction to sit down and relax. That doesn't work. They have to burn off that adrenaline. So you need to take them for a walk or do something extremely physical, and it has to be somebody that's not involved in the debate at all. So those are the behaviors those are common behaviors. If you want to read more and study more about them, the Alzheimer's Association, go to other dementias, and also you can see behaviors, and you can click a whole page that elaborates even more than I have on each of these behaviors that you might be seeing or trying to respond to. So why are they doing this? Well, if you look, somebody with an Alzheimer's brain, there's quite a bit of shrinkage can happen. You can see that if you slice it in half, that the ventricles are not as well formed. The whole brain inside is not as well formed. You can see on a PET scan that there's just not as much firing. So the bright are somebody who's normal, whereas the faded out are somebody who has dementia. And you can see that that's very much like a newborn child in the progression. So I would like to give you a warning. Medications for behavior management, research evidence, as well as governmental warnings and guidance regarding the use of antipsychotics indicate that all individuals with dementia should only use these medications if and when 1. Behavioral symptoms are due to mania, a totally elevated mood, energy, unusual thought patterns, or psychosis where they have a lack of contact with reality, or that the symptoms present a danger to the person or to others, or that the person is so unconsolable or has persistent distress, a significant decline in function, or substantially difficulty receiving needed care. Then and only then would you consider using an antipsychotic. There is, it's called the beers, like that you drink, BEERS. Criteria. It was first developed in 1997 and it's been updated since 2003, and it gives a whole list of medications that really are not appropriate for older adults or older adults with dementia. because a lot of medications can make the dementia symptoms worse themselves, just something like Benadryl. Um, but if you Google that Beers criteria, you'll see a whole list. So I'm sure some of you are wanting to know, okay, so how do I prevent this? Well, you need to control diabetes, because if you have diabetes, they say that you're 2 times more likely to develop Alzheimer's. Hypertension and heart disease certainly come into play in that vascular dementia and can also exacerbate something like Alzheimer's. Remember, somebody can have comorbidities. Obesity, in midlife, you can have 3.5 times more likely. As I told you, in the normal aging, obesity is becoming one of the huge risks in the United States. Chronic stress, 4 times more likely. Sedentary lifestyle, and smoking. After age 65, it can increase even up to 79%. You may remember that long time ago they said that smoking might might reduce your risk of Alzheimer's. But they found out in those longitudinal studies what had happened was the people that smoked didn't live through the longitudinal study. So genes account for only about 25% of an individual's health and longevity, while our environment and personal behaviors account for the rest. And that is information taken from Robert Butler from a recent AARP bulletin. Exercise. Aerobic, they recommend 30 minutes 5 times a week, and they say that that can reduce the risk by 35%. Strength training, you should do 2 to 3 times a week, and with aerobic, that reduces the risk up to 50%. Brain healthy diet, so they suggest that you eat across the rainbow. If you shop primarily in the peripheral of the store, that's where all the fruits and vegetables are. They tell you to focus on that area. Keep your mind active. So whatever hobbies you're doing or whatever you're reading, if you're doing puzzles, once one level becomes easy, you need to move on up to create more axon sprouting. There are 7,000 varieties of axons in your brain, but you want to create the better network that you have up there, the more damage you can sustain. You want to sleep regularly and restful. They're saying that somebody with sleep apnea can have increased risk of stroke and things like that. So if you think that sleep apnea might be a problem and that's why you're not sleeping restfully, you certainly want that looked into. You need to learn to relax. You have to stay connected, have a strong support system, breathe, meditate, use yoga and Tai Chi, any of those things. Remember, if you're constantly on stress, that causes the hippocampus to get smaller. The hippocampus is where your short-term memories get stored before they become long-term memories. And you want to protect your brain, because brain trauma is certainly one of the, can certainly lead to Alzheimer's disease. So you want to avoid toxins and wear a helmet. And Dr. Patricia Boyle believes that a strong sense of purpose in life is extremely important, and that research has even more people are becoming involved in that type of research, because purpose in a life is an indicator of human thriving that has been hypothesized to be related to better psychosocial or psychological well-being. All of us humans want to feel that we have something, that we have a meaningful and purposeful life. And what I see in care facilities is when someone feels that they don't matter anymore and that there's no reason to live, that they tend to fail to thrive. So we try to keep them at their highest practical level and ensure that they can find things that are meaningful and purposeful in their life. So I've talked to you before about normal aging and the losses associated with aging. We looked at multiple diagnoses. We looked at medication side effects there. And tonight we've talked about memory loss and dementia. So thank you for your interest. And David, if you wish to take it over, I will answer questions.